And now I'd like to introduce tonight's speaker. Dr. Joey Jarrard earned a Bachelor of Science degree in Chemistry and Biology from Valdosta State University. He earned a medical degree from the Medical College of Georgia in Augusta and completed his residency in general surgery at Mercer University Medical Center of Navicent Health in Macon. Dr. Jarrard completed a fellowship in advanced gastrointestinal minimally invasive surgery and bariatric surgery at St. Luke's Hospital of Kansas City. He is a general and bariatric surgeon with South Georgia Surgical Associates in Thomasville.
So thanks for the introduction. So we're going to talk about reflux in general, and we'll talk about options for management, including surgical options. Then we'll have some time for questions. If you have any questions, feel free to raise your hand, or if you prefer to save it for the end. This is the team. Again, I'm Dr. Jarrard. I did a good bit of reflux type surgery, foregut type surgery in my time in Macon with some good guys there. I spent an additional year in Kansas City doing this stuff and really fell in love with it. I think it's very effective and patients tend to have a very good response and are very, very appreciative afterwards. So it's very rewarding, and that's kind of when I got into this stuff. Stephanie Thompson is my PA. She assists me in my clinic as well as in the operating room. She's in the back here. And Adela Culler is my nurse. She also assists in clinic. A lot of insurance pre-authorizations and sort of behind-the-scenes things that she's a lot better at than I am. So I really appreciate these guys. So we'll start out. So what is gastroesophageal reflux disease? It's a big and growing challenge. As you can see, 1 in 5 people in the U.S. suffer with reflux or GERD-type symptoms. 21 million people are on PPIs, or proton pump inhibitors, and this includes medications like omeprazole, esomeprazole, Nexium, Prilosec, all these things. Most are over the counter now. 10 to 15% of patients with reflux will develop Barrett's esophagus. This is a change in the lining of the esophagus that predisposes you to cancer. And you have a 40 times greater risk of developing cancer if you have Barrett's esophagus. So it's something we try to avoid. GERD is a chronic digestive disease. It's caused by a weakening in the lower esophageal sphincter. A sphincter is a circular muscle. You have a lower esophageal sphincter, or a circular muscle, sort of at the base of your esophagus here. This is your swallowing tube. This is where it becomes the stomach. Why does that become weak? It's relatively unknown. There are several factors that are unknown, but what we do know, it's something that happens over time. It can increase your risk if you have family history, and they're often associated with hiatal hernias. It's not shown here, but I'll go back to this picture. This junction right here is also at the level of your diaphragm, or your breathing muscle, and that muscle also separates your chest and lung cavity from your abdominal cavity. There are several attachments, ligamentous attachments, that contribute to the strength of your lower esophageal sphincter. So a hiatal hernia is naturally a weakening in those attachments and predisposes you to reflux. So reinforcing those attachments is a part of treating reflux, and that can only be done surgically. So there's lots of symptoms, and as I click this button, more and more circles pop up, and there's lots of symptoms related to reflux and GERD, and some of these are interrelated, but heartburn is a common theme that people describe as their symptoms, and this can lead to hoarseness, regurgitation, or actual reflux and the acid itself can lead to difficulty swallowing over time, cough, sore throat, chest pain, dental erosion, bad breath. There's lots of symptoms that can all stem from this common underlying problem. These are a lot of common problems, and I think reflux as a whole is underappreciated as a cause for these common problems. The quality of life impact, you can have poor quality of sleep. You may wake up in the middle of the night with reflux type symptoms, reduced work productivity, dietary compromises, meaning you want to eat something but you can't because you know it'll give you terrible reflux. You know, you go to an event or a dinner with friends and you say, well, I just can't order that on the menu because I'll have terrible reflux. There's concerns about the long-term effects of GERD, and if you do your research, things that I alluded to earlier about Barrett's esophagus and increased risk of cancer, along with strictures, difficulty swallowing, and problems that you can develop from the long-term side effects of GERD. Another one is lifelong dependence on medication. If you read the back of the box for any PPI that you buy, it'll say take for up to 2 weeks as long as symptoms persist, and then consult with a medical professional. A lot of these medications weren't built to be lifelong medications, and taking a pill every day for the rest of your life, along with other medications that you may have, can be daunting. So back to the complications of GERD. Esophagitis is inflammation of the esophageal lining. This can lead to erosion, as in this picture. A stricture, if you can imagine a circular muscle, if it scars, the lumen of that circular muscle is going to get smaller, meaning it's going to be harder for things to pass. That's called a stricture. Food can get stuck in that. You may have chest pain or feel like things are getting stuck when you swallow. Those are all risk factors for having a stricture. And all that is just scarring as the esophagus heals over time for this chronic insult of acid. Barrett's esophagus, as we mentioned earlier, this is a precancerous lesion. It's caused by chronic exposure to stomach contents from GERD. This is a change in the lining of the esophagus, and not to get too detailed, the actual mucosal lining of your esophagus tries to adapt to the chronic acid exposure. So as it changes from one cell type to another, sometimes it gets a little out of control and can become a cancerous lesion, and that's the gist of Barrett's. Again, this occurs in 10 to 15% of all people with GERD and increases your risk of cancer, adenocarcinoma specifically, by 40 times. This is an endoscopic picture, or with a camera with a light ran down, where you can see significant esophagitis and erosions. This pink, sort of salmon-colored area is Barrett's esophagus, and that's an actual metaplasia or cell type changing from chronic acid exposure. Within that bed of Barrett's esophagus, you see this little erosion and tumor developing, and that's an area of cancer. Esophageal cancer in general is the 6th most common cause of cancer deaths worldwide. It's estimated that there will be 20,000 new cases this year in the U.S. alone. And what's scary is there's been such a dramatic rise in the incidence of this cancer in the past 25 years. And to show that on a graph here, you see all these different types of cancer: melanoma, prostate cancer, breast cancer, lung cancer, colorectal cancer. These are all the leading causes of cancer deaths, but as you can see, the incidence from 1975 to 2000 has been pretty linear. The incidence of esophageal cancer has increased by 600% in this same time frame. So how is GERD diagnosed? Do you think you may have GERD? How do we go to the next step? How do we diagnose it? Anybody with GERD-type symptoms, especially if you're considering surgery, these are the things that I require before any surgery is done. Some of these things should be done just for evaluation and workup, even if you're not entertaining the idea of surgery. A barium esophagram, or an upper GI, this is where you swallow contrast, we take pictures, and that can give us a roadmap to see if there's any obvious tumor there, if there's any compression, if we have a stricture that we had talked about, and can also show if you have reflux. The next thing is an upper endoscopy. This is where we run the light down. An actual camera is placed down the esophagus to look for mucosal abnormalities like Barrett's, or a tumor, or a stricture, or cancer. It can actually look and take pictures and biopsy things. We can biopsy the stomach as well to look for H. pylori, which is a common bacteria that predisposes you to increased acid production, ulceration, GERD, and as well as cancer. So all these things can be done at the time of your endoscopy. Another thing that can be done at the time of your endoscopy is a Bravo study. What this is it's a way of us to measure the pH, or the acidity in your stomach, and the reflux over time. The old way of doing this is putting a tube down your nose and having a little walkie-talkie that kind of you carry around and measure it. Now it's just implanted at the time of your scope. You can't see it or feel it. And it has a radio signal that sends this information, and we can gather it. And it uses a lot of information like how low your pH is, for how long, if you had that sitting up or at rest. And it takes all these numbers and quantifies it into what's called a Demeester score. And that gives us an objective information on whether or not you have reflux. So everybody has to have one of these. The last thing is esophageal manometry. And this is used to exclude motility disorders. So what are motility disorders? Your esophagus is a muscle, and like any muscle in your body, it contracts. Well, since it's a tube that's meant to get food from your mouth to your stomach, it needs to contract in a certain sequence in order to propulse food down into your stomach. Any abnormal contraction or lack of contraction is referred to as a motility disorder. There are several disorders that are named, that are well known and described, that have actual names to them. Some of them don't actually have names. The most common ones, achalasia, diffuse esophageal spasm, and nutcracker esophagus, these are all named disorders of motility. Some of these disorders are treated with surgery. Some of them are improved with surgery. Some of them are made much, much worse with surgery, and you would want to avoid surgery. So that's why we do this test, to identify any motility disorders and if we would be helping or harming you with surgery. Again, even if it's not a named disorder, manometry gives us a lot of numeric information that we can use to decide how well you would respond to a reflux operation. And we'll talk a little bit more about that as we get into different types of reflux operations. So, symptomatic management and treatment options. So, at the forefront of management is diet modification. So, change what you're eating. Spicy foods, caffeine, fatty food, tomato-based foods, all of these things tend to not necessarily intrinsically weaken, but it can loosen your lower esophageal sphincter and predispose you to reflux-type symptoms. So avoiding some of these trigger foods oftentimes helps with your reflux. A lot of people consider this almost like a diet is kind of hard to maintain long-term without having breakthrough symptoms. Bed elevation at night can also help with breakthrough symptoms. And weight loss is right at the forefront again. Excess weight contributes to reflux. The reason for that is whenever you're overweight, you have more fatty tissue on the inside of your abdomen. Whenever you have fatty tissue on the inside, it increases the pressure on your stomach and makes things want to go back up to a lower pressure system like in your chest. Medications. So there's 3 major types of medications for reflux. Some of them address the issue, some do not. Antacids are just what they sound like. They're anti-acid. So all they do is go into your stomach and neutralize acid that's already there. H2 blockers and proton pump inhibitors, they work at the cellular level to decrease production of acid. And these are examples of each of these medications. The benefits of these, again, they reduce the amount of acid production and or they neutralize acid that's already there. They can reduce inflammation of the esophagus and esophageal lining by neutralizing that acid. And they can provide significant symptom relief for many patients, but oftentimes this is only temporary. A lot of patients continue to have breakthrough symptoms. Up to 40% of patients report breakthrough symptoms despite maximum reflux medications. As we kind of talked about how reflux occurs with your lower esophageal sphincter, you can imagine that the medication doesn't address that. It doesn't do anything structurally to strengthen that muscle or to prevent reflux. All it does is neutralize the acid that you're refluxing. You're continuing to reflux. You can continue to have dental erosions, cough, aspiration, a lot of these same problems because the actual reflux is not addressed. It's just the pH or the acid that's addressed. A lot of these medications, like I said, have breakthrough symptoms. Most of these will require lifelong use and dosage increases over time. And there's side effects associated with these, PPIs particularly, including diarrhea, nausea, constipation, headaches. Let's see if this shows up. This is just a diagram to sort of, beat the dead horse here of people have breakthrough symptoms on PPIs or anti-acid medications, regardless if they're on them. The reflux is the same. The symptoms are about 40% of the time you have breakthrough symptoms. There's a long list here of publications, and most of these are from major journals and or the Food and Drug Administration, or FDA, that show increased risk from this benign medication that we think is a miracle drug, the PPI. And I won't knock it too much. It's a good medication. It's great for short-term use. But there's some unknown side effects, or side effects that we didn't necessarily know about when these things came out, that are starting to sort of surface. The FDA showed increased possible risk for fracture with high-dose PPIs. A lot of the vitamins and minerals that you would normally digest that require acid, you're not able to digest or metabolize as well. Calcium and magnesium, you don't absorb as well with these medications. So as you can imagine, it can weaken your bones, increase your risk of osteoporosis over time. Again, low magnesium levels. C. diff, it's a common bacteria. I'm not sure if you've heard of C. diff. Anyone in the healthcare field has certainly heard of C. diff. It's a bacteria that overgrows and produces a toxin in your colon and leads to life-threatening diarrhea. The risk of C. diff infection is significantly increased with PPIs taken long-term. PPIs are shown to increase the risk of myocardial infarction or a heart attack. They increase your risk of chronic kidney disease and progression to end-stage renal disease. There's been an association between people on PPIs and dementia risk. Here's a little news clip here I'll just play for you. And
prescription drugs in America treating heartburn and acid reflux. They're now also sold over the counter. While it's already known they're linked to a risk of fractures and infections, now a new study finds they can have another serious side effect. NBC's Ann Thompson has the details.
Can't afford to let heartburn get in the way.
Stopping heartburn is big business. Sold as Nexium, Prilosec, and Prevacid, more than 15 million Americans shelled out over $10 billion in 2013 for the prescription versions of these drugs called proton pump inhibitors. Now a new study from Johns Hopkins says these acid-reducing drugs may increase the risk for chronic kidney disease 20 to 50%. Cleveland Clinic kidney specialist Dr. Jarrard Cancel is treating Kim Hinkle.
Kim had normal kidney function in March, and then blood work in August showed kidney function down to 30%.
Kim was taking one of the over-the-counter versions. On a hunch, Dr. Cancel had Kim stop, and her kidneys improved.
I was lucky it was caught early, and that we can do something about it.
For over-the-counter acid reducers, the FDA recommends they be used for 14 days and no more than 3 times a year. For the prescription versions, the package insert recommends for most conditions the pills be taken for up to 8 weeks.
Pills are not the only answer. Food is the answer.
Dr. Jonathan Aviv prescribes the drugs, but insists his patients also avoid acidic foods, like berries, chocolate, and anything with caffeine for 28 days.
You can change your diet and reduce acid production and actually heal your own body by what you're eating.
The makers of these drugs say they are safe and effective when used correctly. That and diet can keep stomach acid where it belongs. Ann Thompson, NBC News, New York.
so why consider surgical options? Now that I've painted this picture that PPIs are the devil, they're really not. They're good medications. They're good for symptoms. I'm just raising awareness that there are some long-term side effects that aren't often advertised. So reasons to consider surgery. You continue to experience symptoms despite taking these medications. GERD's negatively impacting your quality of life. Dietary changes, I agree with what this guy was saying. They do help. I don't think it's the end-all be-all. And again, dietary changes are kind of hard to maintain for the rest of your life. So it's a hard long-term solution. Concerns about potential risk and complications of having GERD, and the desire to be free of medications. So what are surgical options? The Nissen has been around forever. It's tried and true tested operation that we've done for a long term. It's the longest standing operation done for reflux. It's got bad press over the years. I think part of that is people performing Nissens that aren't adequately trained in this type of operation. as well as patients not being part of a collective reflux center or practice that oversees before and after surgery. As I alluded to earlier, there's a lot of testing that goes into whether or not you're even a candidate for reflux surgery, and I know oftentimes these type procedures are performed without all of that preoperative workup. So in a poorly selected patient, a Nissen can have complications. I still think it's a great operation, and I still do these on selected patients. In general, these are done laparoscopically through the small incisions. It's a 1 to 2 hour procedure, often requires an overnight stay. A big turnoff to the Nissen is dietary restrictions. You're on the liquid diet for a couple of weeks and then a soft diet for a couple of weeks. If a Nissen is done appropriately, sometimes it's difficult to belch afterwards. So gas bloat is a real option. If you can imagine not being able to belch and then drinking a whole Coke, that's not going to feel very good. Most people lose their ability to vomit. And I know vomiting is not fun, but if you have to, it's kind of good to be able to. That's not everyone, but these are common problems associated with a Nissen. Gastric bypass, I added this in here because I'm a bariatric surgeon as well. So to attack this from two different heads, as I alluded to earlier, your weight or being overweight significantly contributes to reflux. In addition to that, being overweight will increase your risk of having complications after surgery and at the time of surgery. One thing that I try to avoid at all costs is if you have a hiatal hernia that I repair at the time of your operation, being overweight increases your risk of that hernia recurring. I don't want your hernia to recur and this nice fancy device I just put in go up into your chest. So that would be extremely rare, but anything that would increase your risk of that happening, I try to avoid. All that being said, anybody with a BMI greater than 40, I would try to talk them into weight loss surgery, particularly the gastric bypass. The two options we offer here are the gastric sleeve and the gastric bypass for weight loss. The sleeve can be refluxogenic, I don't know if that's a word, but it can worsen reflux because you really have to take down some of those attachments to your diaphragm in order to get a sleeve. Now, most people say after they've lost their weight, their reflux is better, but anybody with significant reflux that's on medications, that have refractory symptoms, if your BMI is greater than 40, a bypass is a very, very good option. The reason for that, as you can imagine, acid produced here in the stomach is disconnected and has no longer any way of getting back up to your esophagus. This is curative for reflux for most people. Moving on to the reason we're here is to talk about the Linx. Linx is a reflux management system. I think it's state-of-the-art. It's been around for over 10 years now. We've got great results from it. I just think it's the greatest thing since sliced bread. I'm just trying to talk everybody else into this. It's been FDA approved since 2012. It has been performed for longer than that. That's just when it actually got its FDA approval. It's proven safe and effective. Our 3-year data was produced in the New England Journal of Medicine as a safe operation. 5-year data was eventually released. The 10-year data from this operation is written up and available but not published yet. So I will hopefully mention that at my next health talk. It's a minimally invasive procedure like a Nissen. These are done laparoscopically. I can also address a hiatal hernia at the same time as this operation without additional incisions. And this is designed to be a permanent solution for GERD. So how does it work? So just to point here again, here's your stomach, and here's your esophagus, or your swallowing tube. Here's that muscular lower esophageal sphincter that we're talking about. Well, as this gets weak, all we do is reinforce it with these magnetic beads that are connected to each other. So we just place this around where the lower esophageal sphincter is, connect it to itself. When you swallow food, it stretches and allows the food bolus to pass, and then it falls back into this orientation and does not allow refluxate to come back up the esophagus. It creates a one-way valve. It's new. It's brand new at Archbold. I'm the only one doing these here now. It's brand new here. It's been around since 2007 was the first one done in the U.S. So it's not a brand new operation. It's just brand new to Archbold. Back to the Linx procedure. Again, this is done laparoscopically. The small poke hole incisions usually takes less than an hour. Now, if you do have a large hiatal hernia, it might take me a little longer to do that. The benefit of this that most people like over a Nissen you eat regular food immediately. I have you on regular food the evening after your surgery, and I actually encourage you to eat. It keeps these magnet beads open if you eat every 3 to 4 hours, swallowing something. Keeps the beads popping open and functional as the scarring takes place and as the healing takes place. So there's no period of liquids following surgery, which a lot of people like. There's no alterations to the stomach. I don't mobilize your entire stomach and wrap it to itself. I don't alter your anatomy at all. I'm just putting a device just above your stomach.
I have a question.
Sure.
About you talking about while the beads keep them opening and closing, while the scarring is healing. What scarring?
After any surgery or any violation to any organ, there's healing takes place or scarring takes place. Scarring is a natural process of healing. That's just how your body heals itself, is through scar. Anytime you have a foreign object or anything in your body's natural tendency is to form a tissue around it to sort of encase it. And that's what happens naturally with the Linx. And we actually like that. We want that to happen, because once that scarring and tissue forms around the Linx, it keeps it right there. The Linx can't move up and down, doesn't go anywhere. It just stays right there where we want it to be and solidifies it as a permanent option. So there's scar tissue has a negative connotation, the word scar. Healing tissues is a better word to use. It's as it heals in place, as your body gets used to it being there, we don't want that healing to take place when it stays closed. We want it constantly kind of opening and closing.
Okay, so if you don't like it and want it removed,
It's removable.
and it's removed, then the scar tissue doesn't cause any weird feelings.
No, a lot of the scar tissue is from the device being there itself. Now, what we have, that's a very, very good question. The other thing that we found oftentimes in patients who decide that they don't like the device anymore, but who's had it long enough for that scar tissue to form, once we take it out, that scar tissue's there and actually does a good job of reinforcing your lower esophageal sphincter. And even with the device gone, your reflux is better than you were at baseline.
Good.
Okay. What would cause you not to want it?
I have no idea.
Some people, everything bothers them.
There is about a 2 to 3, I think it's 2.7% removal rate from these. And that may range from anything from people have vague symptoms that they attribute to the only thing new that just happened to them. Some of that might be from dysphagia or difficulty swallowing. There is a period after this surgery where you will have a little bit of difficulty swallowing. Most people. They say it's minor, eat smaller meals while this happens. After a few weeks, it goes away. The Nissen, the same thing. You have dysphagia immediately after your Nissen for a couple of weeks, and that slowly gets better. Yeah. Same thing with the Linx, except you have a honeymoon period where the world is fantastic immediately after surgery, and then you get a little bit of dysphagia for a few weeks, and then that kind of goes away, and then everything's wonderful again. So that's a natural process that happens in everybody, and that's just the process of this scar tissue forming. Yes, yes. That's the benefit of this over the Nissen, is most people maintain their ability to belch and vomit. I'm not shedding any negative light on the Nissen because I think it's a fantastic operation and I still do them. Yeah, yeah, yeah. Well, you still have options.
But if you were to choose one for your family member, you would maybe choose this last.
It's a loaded question. There's a lot goes into the workup. I try to look at any manometry that's done. I'll kind of look at it myself, and we were talking about this. I'm not a qualified manometrist, and I don't bill for it. But I like to eyeball all mine because there's certain numbers that you look at in manometry. And even if you don't have a named motility disorder, it may say you have an extremely weak lower esophageal sphincter or a non-existent lower esophageal sphincter. Well, in that case, you may need a Nissen or a little bit more aggressive surgery. Or they may say that you don't have good propulsion of food down your esophagus. Your peristalsis is just really, really, really weak. In that case, a Nissen could be devastating for you because you'd have severe dysphagia and inability to swallow. So I kind of eyeball the manometry. In an even playing field, if manometry is 100% normal, the rest of the workup, not normal, but the manometry is normal, but you have reflux and reflux symptoms that are proven by these other tests, I would Linx my own mother. I mean, I believe in this. I wouldn't operate on my own mother, but you get the point. I would really, really get my partner to do it. Benefits long term. So this is what everybody likes to hear about. It works early on. How, does it work later on? Well, I can't talk about the 10-year data because it's not officially published. I've heard it's just as good as the 5-year data. And I do know that the 5-year data says it's just as good as the Nissen as far as efficacious-wise. It works fantastic with some of the fewer side effects like gas bloat and those type symptoms. 85% of patients are completely free of daily reflux medications, and this is after 5 years. 88% have reported that the bothersome heartburn has been eliminated after the Linx. This is the great one, reflux. So we talked about how the pills work at neutralizing acid and helping with heartburn. They do nothing for reflux. This is where the magic happens, is reflux. 99%, almost 100% of people say that their reflux is gone after a Linx. I did a guy in Kansas City, I like to tell this story. He's had reflux forever. We put a Linx in him, and he gave me a call like a week later and said that he was eating hot wings with jalapenos cut up in his chili, trying to get reflux and couldn't. The reflux is gone. And I was like, well, I don't recommend you do that, but it's a good little testimonial. Free from bloating, and this is what you're asking, free from bloating. So you're able to belch, you're able to vomit if you need to, so that gas bloat feeling after a Nissen is much better with the Linx, with the same benefits. In summary, GERD is a chronic digestive disease caused by weakening of that lower esophageal sphincter. It's much more than heartburn or indigestion. It's a spectrum of symptoms all related to a common problem. Complications like esophagitis, strictures, Barrett's, esophageal cancer have all directly been related to GERD. And this is the biggest reason that the rate of esophageal cancer has come up over all these years, is the types of cancer that you're developing is now adenocarcinoma, not squamous cancer. Adenocarcinoma directly related to GERD. Squamous cancer is the one more related to tobacco use. So it's specifically this type of cancer that has increased so much over the past 20 years. Medications may provide symptomatic relief. We know that they work. 40% of people continue to have breakthrough symptoms despite their medications. They do not affect the underlying cause of GERD. They have no effect on the actual reflux or mechanical cause of reflux. And most of these will require lifelong use to maintain your symptomatic relief. So, questions? Any more questions? Yes, sir.
The Linx device, what is the elasticity used to allow it to expand and contract?
It's magnetized. Very good question. It's small titanium beads. They're all connected with little metal wires, and they're titrated, they're magnetized, and they're carefully titrated to be just weak enough to let things go through, but strong enough to overcome the pressure of gastric content coming up. And that pressure is greater than 40 millimeters of mercury, I believe. Sure. It does not weaken. The half-life of these magnets are usually beyond our own half-lives, and they're meant to stay. There is a rate of these things breaking that's been reported. I don't know what the number is for that because it's far below 1%. Breaking or becoming less efficacious. If you see that, normally you can just get an x-ray and all the beads aren't stuck together. They're broken or separated. And in that case, it could be easily replaced. Or as I said, if you just want to take it out and give it a trial, most people are better from that scar than they were to begin with and may not need anything else. Very good question. They're all independently connected, so you can cut it and they would be all stretched out again. You have to cut it in multiple places to actually individualize the beads. It's not like a pearl necklace. If you're having recurrence of your symptoms, that's usually how we find out that it was broken. Again, this is more hypothetical because it's so rare for that to happen. I've only seen 1 or 2 cases of that of somebody else's. I've never had one break. But usually you have a return of symptoms. A simple x-ray will show that those beads aren't all together. They're more like this. And if you have to go in and take it out, usually, you know, make a little incision through the scar tissue and you just pull it all out as one little unit. They don't fall all over the place like a broken pearl necklace.
Would it be because of your diet that you're eating too much at one time and trying to swallow too much at one time and so it forces it open? When are you sure?
As a cause for it to break, is that what you're asking? I don't think so. I mean, this is titanium. You can't break it with your hands, let alone with swallowing. I don't know why they would break. Again, I've never had a patient had that. I've only seen like a report of one.
Would it help with aspiration?
Yeah, if you have aspiration related to this, absolutely. Aspiration is a product of reflux, and 99% of people have none after 5 years. Somebody over here had a question.
I just want to know, is this Linx similar to the one that they use when they're trying to lose weight?
A lap band? This is different. A lap band is bigger and a little bit bulkier. It's connected to a tube and a port under your skin where you have to constantly adjust the fluid in and out of it. This is very carefully titrated magnetized beads where there's no maintenance, there's no following it. It's you put it in, and it's much smaller than a lap band. It opens and closes, whereas a lap band is rigid, and there's really no give or take. It's just there, and it's as tight as it is unless I adjust it. These are meant to stretch and sort of work with your esophagus to allow you to swallow, but not reflux. There's a rate of infection for any surgery, like a surgical site infection or a skin infection. You know, that's 1 to 2% with any surgery. I think what you're getting at is the effect of having an infection around this thing. That would most commonly be caused by erosion, or if this eroded into your stomach. The rate of that is 0.2%. Most of those came very, very early on when we started doing these because we were putting them in too tight. We thought the tighter the better to get rid of the reflux. Since then, we've learned that you can put them in a little bit looser and they still have the same effects, and our erosion rate has gone down. But our global erosion rate is 0.2%. It's extremely low. If that happens, you just go in and take the links out, and you may or may not have to reinforce or put a stitch over that area.
Does your primary care doctor have to refer you to need to get the surgery done?
You can refer yourself tonight. I mean, you can just give me a call. We'll make it happen. Some people report headaches after some of the PPIs. Reflux doesn't tend to cause headaches. It's more that some of the medications can cause your headaches. In the back here, yeah.
If you already have this stage of coagulation, that doesn't, when you put the links in and it tightens, does that affect your ability to swallow?
That's a very good question. In a patient with achalasia, I would not recommend one of these. With achalasia, have you had surgery for your achalasia? That's the question. If you have achalasia, what you need is a Heller myotomy, where you actually split the muscles and weaken that area. The problem from reflux typically is not so much that things don't work right, it's that it's rigid, so it's a failure to relax. It's sort of the opposite problem. Your lower esophageal sphincter doesn't relax like it's supposed to. So a myotomy, or going in and splitting those muscles, allows that to relax. Now, a side effect of doing that procedure is reflux, because you've kind of gone the opposite direction. So most of the time when I do a myotomy, I do a reflux operation at the same time, but that's generally a toupee or a door fundoplication. I don't tend to put links in after a myotomy. That's a very, very good question. I would do a traditional tissue fundoplication. Yes, ma'am.
What if you have some of the other spasms, esophageal spasms, that's not exactly what kind of treatments would you do, like for, I don't know, nutcracker or
Yeah, most of those things aren't treated with surgery. Surgery is sort of a last resort for, say, diffuse esophageal spasm. That would be a long myotomy up into your chest, a little bit higher risk, more complicated surgery. Most of those respond to medications, and medical therapy is first line for Nutcracker and DES. You had a question here.
Yeah, I've been on one of those long-time inhibitors
Sure.
for a long time. And so I have some concerns about that when I have to watch it. That even though it's a small milligram each day, right before I eat breakfast, but I just have some concerns about that.
I don't mean to scare you to death about a medication that 21 million people take. I'm just trying to bring to light that it's not quite as benign as we've always assumed it was. If you're not actively having problems and a small dose completely knocks out all of your reflux, you're probably safe to stay on your current regimen. If a concern for these complications kind of keeps you up at night, or you start noticing abnormal kidney function, or if you get a bone scan and you're developing osteoporosis, if you're having any of these problems, it's very well worth looking into surgical options. If you're not having any of these problems, your gastroenterologist follows you closely and says it's safe, it's probably safe. The trap that we run into is a lot of patients are followed their entire life by their primary care physician for reflux and given some of these prescriptions, and they never see a surgeon and they never see a gastroenterologist, so they don't really always get all the workup that we need to make sure you don't have any of these bad things. So if you have a little bit of reflux after you drink too many beer or eat a bowl of chili, that's a little bit separate from having daily life-altering reflux that isn't really responding to medications. And if that describes you and the only physician you've seen is your family doctor, I'd recommend a referral to someone who deals with a little bit more of this.
Well, I am on the gastroenterologist.
If he thinks it's safe and you're not having complications and you're fine with no breakthrough symptoms, I can't really talk you out of that.
But I do stay away from all the spicy stuff. If I do eat something spicy, it bothers me. But as long as I just stay on the foods that I need and the drinks, so far I haven't had.
And that's fine. If it's really a struggle for you to maintain those dietary changes, any of that stuff, I mean, it's your decision. You're sort of in the safe, benign zone where it's going to be completely up to you if you want to try something else. If you're happy where you are, then I'm not going to try to talk you out of it.
But that doesn't mean that I might not come see you. Many people complain that they have difficulty swallowing though because of the magnets, or it doesn't seem to bother them.
Yeah, so the period that we talked about, most people call it the honeymoon period. The day after surgery, you just want to go eat a bowl of chili for the first time, is what most people have described to me. Like, you feel fantastic, you have no reflux, you feel great. After a few weeks, sort of the scarring period or healing process takes place. That usually lasts a few weeks, and during that period, dysphagia or difficulty swallowing is common. For most people, it's not life-altering. It's not, you can still eat and drink, you just kind of notice maybe it's something discomfort there. We have medications we can treat if it's bad enough for medications. Most people say, I can notice it, but it's not terrible, so let's just let it ride. After the 8-week mark, when things are kind of healed in and doing great, then most people can look back at their dysphagia. It's a very predictable time frame that people get it in. And I think as long as you know that up front and don't panic and think something's wrong, most people are fine. They get through that small phase, and then you're happy. You're just so happy you're not having reflux that you'll live with a little bit of dysphagia for a few weeks.
Now, what about people that produce too much acid? Like, she was diagnosed, my daughter, with nocturnal reflux, and that's where their bed elevated and everything. She did the Bravo thing, the endoscopy, the whole 9 yards. And they said she had nocturnal reflux, so she takes like famotidine before bedtime, and in the morning she takes omeprazole. Okay. So she gets on it for about 5 years. So, if you have, my question is, if you have the Linx thing done, what about all that acid that's in your stomach? Is that cause?
Your stomach is very, very well equipped to deal with acid. That's what its job is, to deal with acid. Okay. And your duodenum, or the first part of your stomach, or after you leave your stomach, the first part of your intestine, has all these glands that secrete basically Tums in liquid form. It just shoots it and neutralizes all the acid. Your stomach is used to acid. So as long as you're not having severe like ulcerative problems, like peptic ulcers, gastric ulcers, that's sort of a separate problem. But your stomach's well equipped to deal with acid. Your duodenum is well equipped to neutralize the acid. And a lot of symptoms that you have is when the acid starts irritating your esophagus, which is not equipped to deal with the acid. So if we eliminate the reflux, your stomach could usually deal with the acid.
Okay, thank you.
Hey.
Yes, my husband, we know he has a hiatal hernia, and I heard you say that his Linx would be another, you could also repair that while you're in there. Would that hiatal hernia be a reason to go straight to Linx, like to come to you for that?
Not necessarily. There are multiple types of hiatal hernias, the most common being what's called a sliding hiatal hernia, and that's just where the top part of your stomach or your gastroesophageal junction just slides up and down into your chest freely. That's one of the number one causes of reflux in general. The treatment for that is usually medications. That is not an indication for surgery. The indication for surgery would be if the reflux symptoms aren't controlled. Okay, so if we do the surgery, I would address the hiatal hernia at the same time because, like I said, the hiatus, all those muscles and ligaments around the diaphragm, they contribute to strengthening the lower esophageal sphincter. So part of fixing his reflux would be to fix the anatomy and then give him a Linx to prevent the reflux from the future. A type 1 or sliding hiatal hernia is not in itself an indication for surgery. The indication would be uncontrolled reflux. Now, if you have type 2 or type 3 paraesophageal hernias, that's when a different part of the stomach comes up or another organ comes up, that's a type 4, or if a major portion of the stomach comes up into the chest, that can be an indication for surgery if you have symptoms from it. And I repair all those at the same time. There's a bit of a spectrum. You know, I'd say if I looked at everybody, I could say maybe that's a hiatal hernia. That's not really what I'm talking about. I'm talking about the big ones. Those require repairs and often an overnight stay in the hospital if we do that. A Linx by itself without a hiatal hernia repair can oftentimes go home the same day. So, did that answer your question? I'm just getting to a whole speech about types of hiatal and paraesophageal hernias. There's a few of them. I think she had a question here first. What determines it? We pick it up on these tests. Often all it is on an endoscopy where they run the light down. Sometimes you can tell from the x-rays, the contrasted x-rays, that part of your stomach is above your diaphragm. That's how we diagnose it. And like I said, if it's just a sliding hernia, and usually your doctor can kind of tell you what kind of hernia you have from imaging. If it's a type 1 or a sliding hernia, those are the same things. That is not an indication for surgery. If you have a type 1 or sliding hernia and just profound reflux that isn't controlled, that's an indication for surgery, and I would fix your hiatus at the same time. Type 2, type 3, type 4, those are all indications for surgery if you have symptoms. Does that make sense? Sort of two separate, the hiatal hernia and then the reflux are two separate things.
I never got the type. I know that no.
Well, that'd be good to know. Regardless of what type you have, if you have terrible reflux that's not controlled, it's worth looking into.
What is it about in older people who don't have enough stomach acid?
That's due to atrophy. That could be atrophy from some of the glands that produce stomach over time, dietary changes that occur as you get older, are less stimulating for some of those cells to be produced. So they just say, well, I'm not needed, so I'm just going to take a vacation. So less acid is produced over time. And that can lead to some of the same mineral deficiencies as a PPI can on a younger patient, just purely from lower acid production. I can't fix that. That shouldn't contribute to a reflux and a hiatal hernia. Sir.
Wouldn't lifestyle changes come in?
Absolutely, and it was bolded on that slide. Changing your diet and things like that, losing weight, do all those things and your reflux gets better, most of the time.
I was in the military. heartburn, serious heartburn. And I just decided that I'm going to quit smoking and cut back on drinking.
Yeah.
You know,
It's a good idea.
that wasn't helpful. But when I did this, my heartburn just practically went away. And drinking military coffee. I cut that out altogether.
There are certain types of food, caffeine included, certain medications, all relax your lower esophageal sphincter and predispose you to reflux. So avoiding those diets and medications can...
I got rid of that heartburn. I mean, absolutely.
Yeah.
I haven't had it in, I don't know how many years.
You changed your diet too.
Well, absolutely.
Well, yeah, lifestyle modifications, losing a little bit of weight, you know, avoiding triggers, all of those things. If that works, fantastic. You don't need to come see me. You don't need to see your gastroenterologist anymore. You know, we all lose a job here because most people it doesn't work long term. But good. Any other questions? Sure.
Can you have an MRI?
Very good question. So the old MRIs were stronger than we thought than they actually needed to be. Since then, I think 80% of countries or hospitals in the country have upgraded to the newer MRI system. It's a slightly lower strength, and that is compatible with Linx. You can get an MRI with that type of Linx. You'll have a card. All these your official card carrier after a Linx. Anytime you need an MRI, show them the card, and they'll check the strength of the MRI that they want to scan you with, and they'll say, "Oh yeah, this is less than 0.8 Tesla, and you're good to go."
And X-ray machines and all that?
Nope. You shouldn't. If your risk rate is increased, then let me know. But I have not heard of that at airports. Good question. Anybody else? All right, I'm gonna start charging you.
Well, I was ready to pay. I wanted to ask if you see people on Fridays, because Friday...
I'm the only person that does see people on Friday.
You're the only person that does? Fantastic. And we'll be a paying customer.
I just, I'm too young not to work every day. All right. Well, thank you guys so much for coming out despite the weather. I really appreciate the turnout. It's a good turnout.